Today we are entering into the era of interventions in cardiology. And to begin with, today's first session is about BOUT 12, which is this case on heart failure and devices. So for this session, I would like to invite Dr. Chirayu Vyas, Dr. Tejas Shah, Dr. Priyanka Agrawal, Dr. Shubham Sharma, Dr. Asmukh Shah, Dr. Gunjan Shah, and Dr. Vicky Grewal on stage as chairpersons and moderator. I would like them to introduce our speakers and also introduce the case and introduce our speakers. Dr. Varun Sibal, you can also please as the chair. Priyanka was there. Dr. Asmukh, please come on stage. Please start. Dr. Priyanka Agrawal was here. There in the please. Chirayu.
Hello.
Audible.
Hello. I hope I'm audible. Good morning to all of you. Today's topic, the first one is regarding electrophysiology. That's basically heart failure and devices. The case presentation is a 55-year-old male with grade 2 dyspnea is showing a left anterior hemiblock along with an associated right bundle branch block. So a typical bifascicular block with a QRS duration of 130 milliseconds, but with a PR interval on ECG of 240 milliseconds. His 24-hour Holter, the long-term rhythm monitoring yielded pauses of more than 3 seconds. He had a history of cardiac syncope according to typical presentation, at least thrice over the last 1 year. He has an history of an old enteroceptal myocardial infarction with recanalized coronaries on angiography, and his cardiovascular MRI showed a typical small apical scar with an LV ejection fraction of 42%. So apart from the medical optimization, what are the further options? That is what we need to discuss. And the learning objectives being in the sense of evaluation of the syncope as an etiology and the further management, the concept of his bundle or left bundle pacing, the conduction system pacing, versus actually a use of CRT-D in such kind of patients. I think so. I just hand over to the mic, the presenters.
Joining us. So we all know the patient profile. We all know the patient profile. He's a 5 years old. Pacing, has pacing in. I'm here. 30. What are his pacing indications? I'll not go to the trials and all. There is some case. He has PR interval of 240 milliseconds, has left anterior hemiblock with a right bundle branch block. QRS is 130 milliseconds in duration, and he has history of multiple episodes of cardiac syncope and also pauses demonstrated on his Holter. Then why BIV pacing? We do not know the nature of the disease. Then he has presented to us with a diffuse conduction system disease. Scars are patchy. Although MRI shows an apical scar on a cardiac MRI, and his recent angiogram shows a recanalized coronaries. Whether this is an infiltrative disease, he needs further workup. Then in this diagram, you can see there's a CRT versus left bundle pacing. You have a right RV pacing lead, and below that, when you study basically the right bundle and this is the left bundle. Scars an old anteroseptal MI, which was surprisingly not visible on the CT, but he has an anteroseptal scar, so we assume that conduction system may have been affected there. There is an obvious visible scar on the apex, so yes, that can also affect the conduction system. When you pace with an LV lead, you are able to bypass these obstacles. Fortunately, in left bundle pacing, theoretically, you may not be able to bypass this obstruction. You may pace little distally, but still it won't capture the later half of the myocardium. We also do not know the status of the rest of the myocardium. So in my case, I would prefer a CRT, although his ejection fraction is 42%, and he is a very finicky patient that he wants to do only one procedure. I may keep the pacing lead if required in a backup pacing mode, so for future needs. So here the conduction system appears to be progressive in nature, and further workup is required to come to a conclusion. If it is progressive, then reliability of left bundle pacing alone will be questionable. CRT in heart failure has a lot of evidence, multi-center randomized control trials versus an observational studies have been done. And extraction of a chronic left bundle pacing lead, the safety data is inadequate. Thank you.
I think so. Out from your side.
Me acknowledge first he has made a wrong decision granting CR case. Why so? Let us first look at the case. And whenever we look at the data of can I do it manually? Whenever we look at the clinical data, we have to differentiate what is clinically relevant information from the noise. And in this case, the most important clinically relevant information is that the patient has a history of cardiac syncope. He has in ECG bifascicular blocks, first degree AV block, and QRS duration of 130 milliseconds. And in imaging, he has ejection fraction of 42% with scar limited to LV apex. 24-hour Holter mentioning pauses more than 3 seconds, I would consider it as a very non-specific thing, because pauses itself does not mean anything. You have to see whether these pauses are related with patient symptom, what time these pauses have happened, whether patient was asleep during these pauses that were documented, and what is the character of the pause, whether it is related to AV block, sinus pause, whether this AV block related pauses were accompanied by sinus rate slowing. These are very important information before we make a decision on basis of pauses. Now, cardiac syncope, he is a lucky patient that he has come to you after 3 episodes of cardiac syncope last 1 year, because the prognosis is very grave in such patients. 30% of mortality within 1 year of having cardiac syncope. So these patients require thorough evaluation and an aggressive management whenever the opportunity is given to the clinician. Cardiac etiology is presumed on the basis of history. So what we try to do is we try to rule out the most common form of syncope from the clinical history, that is vasovagal or reflex syncope. Usually it is characterized by specific triggers, signs of autonomic activation, and premonitory symptoms. Usually in cardiac syncope, you will not have premonitory symptoms. It can happen even in the lying down position. You can have this syncope during exercise. Suspected arrhythmias usually warrant a device therapy in cardiac syncope, and the goal of device therapy is to offer a complete long-term solution for the patient without increasing short-term and long-term procedural risk. Long-term procedural risk, I also try to include any upgrade that is required in future because of the wrong decision making in the first presentation. Now ECG has right bundle branch block, LAHB, PR of 240 and QRS of 130. So bifascicular block with history of cardiac syncope, most common cause of syncope is advanced AV block in such cases. Still, because there is no documentation, it is suggested that EP study should be done in such patient. Usually EP study has a high positive predictive value. If you find an abnormality in terms of prolonged HV interval, evidence of intrahesian or infrahesian block on incremental atrial pacing or drug provocation, the chances that this patient's syncope is related to AV block is very high. But if EP study is negative, still this patient can have syncope related to AV block. So positive EP study has a very high impact on decision making. Negative EP study has no such impact, and if negative EP study comes, this patient should be subjected to implantable loop recorder, and you may find that 50% of patients who had negative EP study will have syncope because related to AV blocks. So systemic evaluation of such patient with bifascicular block and cardiac syncope is required. If ejection fraction is less than 35, usually you would like to add defibrillator in this patient. But if it is not so, you would like to subject this patient, try to find out the cause to EP study and subsequent ILR to look at the cause of syncope. In imaging, cardiac MRI has shown ejection fraction of 42% with scar limited to LV apex. Now, any patient who has structural abnormal heart with evidence of scar in heart, VT remains an important cause of syncope in such patient. So again, EP study and ILR based systemic approach will lead to diagnosis in such patients, whether it is related to tachyarrhythmias or related to AV blocks. But remember, even in patient who has scarring, bifascicular block, AV block remains the more important cause as compared to ventricular tachycardia in studies that has been done. So when you decided to pace these patients, the goal of pacing in patients with LV dysfunction is maintain AV synchrony and prevent RV pacing induced dyssynchrony. Can't just go ahead and implant an RV lead in patient who has got LV dysfunction, because this patient will come with decompensation of heart failure. Patient who is in class 2 now will come back to you with class 3 and class 4. So you have to think about preserving the LV synchrony or preventing delay in such patient. Now there are 3 ways of preventing RV pacing induced LV delay. Either you put a CRT as described by Dr. Sameer. CRT, essentially what we do is we try to pace RV and epicardium through coronary vein, generate a 2 electrical impulse which gets fused, and LV activation time is shortened because now you are pacing from 2 distant sites LV. But remember, CRT has its role in patient who has LV delay to begin with. Either they are patients with left bundle branch block or patient who has complete AV block and they are dependent on RV pacing. Here our patient not having AV block. He is having right bundle branch block and only 3 episodes of syncope 1 year. That means he is not going to require CRT pacing most of the time. Conduction system pacing, in contrast, not only acts correcting the LV delay in left bundle branch block, also helps in preserving LV synchrony in patient who is completely dependent on ventricular pacing. And in contrast to CRT, it can be done in patient without LV delay and still maintaining the LV synchrony. So unfortunately, if you are implanting a CRT, we have to think of 2 scenarios. Number 1, patient progresses to complete AV block and becomes dependent on ventricular pacing. In that case, probably CRT is fine. But as in this case, where patient remains in normal sinus rhythm most of the time, there is minimal need of ventricular pacing. You are introducing dyssynchrony in a patient who has normal LV size and only apical scar. So this patient is going to get worse with CRT. Remember, this is the landmark trial on basis of which we implant CRT in a patient with LV dysfunction. This slide is very amazing. If you look at the graph, RV pacing versus biventricular pacing, if biventricular pacing is substantially good than RV pacing, I would like to see the graph getting divergent of each other. Now here what is happening is biventricular pacing graph runs parallelly to RV pacing. It only happens late in the course. So it does, the adverse clinical events continue to happen, but it happens later at the time. So though it is better than RV pacing, it's not an ideal solution in patient who has got LV dysfunction and requirement of RV pacing. In contrast, if you look at the conduction system pacing, you can see that clearly the curves are divergent from each other. So RV pacing curve and LV pacing, so there is clearly demonstrable benefit of conduction system pacing over RV pacing. And this is obviously driven by a patient who requires pacing more than 20% of time. I'll take 1 minute, one or 2 minutes. Now this is a beautiful slide which tells that if patient has no LV activation delay or no dyssynchrony, introducing this patient to CRT, you are promoting dyssynchrony because it only corrects the dyssynchrony when it is present. In RBBB, you know that there is no LV delay, and these are the multiple CRT trials where they have seen that only patients who have LBBB benefit and not the patient who have right bundle branch block IVC. That is why the guidelines tell CRT is not recommended for patient with NYHA class 1 or 2 symptoms and non-LBBB pattern with QRS duration less than 150 millisecond. Remember, here we had 130 millisecond of QRS. Ending the presentation with the slide. Here, this is a real life case. Same patient, 86-year-old female, CAD, EF of 40%, and she had right bundle branch, left posterior hemiblock in past. In between, patient had right bundle branch block, left anterior hemiblock. Then eventually she presents with syncope and AV block. And this patient, for all the reasons that I described, was subjected to the conduction system pacing with QRS duration 108 millisecond. This was done in 2020. It's now 24. Patient is 91 years old, still coming in follow-up, hale and hearty. So in summary, syncope warrants thorough evaluation for the cause, and for the selection of device, it's not the documentation of AV block or sinus pause, You have to understand what is the estimate of pacing that is patient going to have, what is the baseline LV function, atrial fibrillation, need of defibrillation, elimination of risk related to upgrade should be considered while treating this patient. And I firmly believe that CSP may not replace CRT for heart failure indication, but it might replace CRT for all the pacing indication. Thank you.
Dr. Neeraj, just a small query, if at all we can just solve that part. The presence of this case having an apical scar on cardiac MR, if at all we think that the scar extension is inside the interventricular septa and maybe involving the typical conduction system and especially the left bundle branch, which is what is not very much specified, especially on the cardiac MRI report. And the purpose of maybe putting a left bundle pacing lead, even if you just try to project it as distal as possible, maybe probably empirically trying to avoid the scar location and putting it distal to the scar, but still if at all, the scar is an extension distal to the pacing lead position. That is what, how do we encounter that problem?
So, a very valid and good question. Remember, when we are looking at we are pacing the conduction not dependent on the location of, dependent on the site of conduction block. So if your conduction pacing resolves that conduction block, means that your job is done. And that is going to be determined by the QRS complex that is created by conduction system pacing. This patient has only apical scar. There is healthy septum, recanalized LAD, and I don't see any reason to withhold this patient a conduction.
Basically what I wanted to tell
Second thing, I would still consider this patient has a conduction disease in addition to the enteroseptal MI, previous MI. I don't think this MI has led to conduction disease itself, because any MI who has to produce a conduction, I think there has to be have some septal scarring.
That is what I mentioned. That is what I mentioned. The extension of the apical scar in the interventricular septa involving the conduction system, especially the left bundle itself, which is what just pacing the typical left bundle per se would not maybe give you the adequate the parameters what we want in terms of conduction system pacing. That not evidence of QR maybe in lead V1, and if at all you are having that thing on table, then there is no option. You need to switch over to CRT, as Dr. Sami is mentioning. This is what would be at least tackled by that part.
Yeah, so I would only withhold conduction system pacing in those patients where there is septal scarring.
That is what we just discussed, that in that case, Dr. Samir, what he pointed was the next option, that if you are not having left bundle pacing lead parameters on table, then obviously switching over to CRT is an option.
Probably later on.
Upgrade, I would not consider a very good option. If you look at the all electrophysiology, upgrade has the highest rate. Not only the hematoma, infection, requirement of transfer, everything. Upgrades is not a great solution. So all attempts should be done to prevent patient from getting an upgrade. So if patient has LV dysfunction, better to implant CRT now rather than upgrading that 2 years later develops severe LV dysfunction.
Sorry, one last question to Dr. Samir. Would you consider in any way maybe just going, if at all, to measure the HV interval, simultaneously maybe try to modify the substrate of the scar location and maybe just try and optimize the antiarrhythmics, if at all just wanting to prevent an ICD lead, maybe a CRT-D?
I mean, not prevent putting in a device and do all
And go for the substrate mapping. And
he would in future would require a pacing, as a pacing, I would go ahead with a pacing.
yeah.
So I think real world controversies come when the LV dysfunction is not as per the guideline cutoff. So if you have this patient as a EF of 30%, you know that it's going to end up with the CRTD. If the patient had EF of say 50%, you would actually not even debate about CRTD. Again, the scar, if you have a huge scar burden, say 20% of the myocardium, you think of an ICD. Again, scar burden quantification is still not a substantiated indication of putting as ICDs, because ICDs are only in the post-ACS scenarios where you have acute MI and you want to prevent a sudden cardiac death. But in a chronic scenario, how much the scar burden would actually be contributory or responsible for guiding you to put an ICD if the EF is not as bad as what is the cutoff of 35 or 30% beyond 40 days or 28 days, depending on the scenario that we are saying. If there are any comments on that from the panel or any other speakers.
Just wanted to point out the fact that how do we rule out maybe the scar VT as an etiology of cardiac syncope? Not considering ICD, that's a different aspect, but maybe ablating the substrate of the scar.
So I think
along with that
basic
optimizing the
EP
anti-arrhythmic.
study will be the very important way of next step, irrespective of whatever you choose on either of the sides.
Yeah, so conduction block in ECG without AV block document. I think keeping the fact that in mind that negative EP study still does not rule out AV block as a cause of it. But if your HV interval is 90, then you have a very clear indication of.
And sir, besides the HV interval, I think we can also see the left bundle to ventricular activation time. So if it is prolonged, then it will also indicate that it is actually the myocardial disease also which is contributing to this thing. And then in that case, we can go for another, besides placing the LV left bundle lead, we can place an CRT lead also, because we don't know how the disease will behave in future. So in that way, we can put in a BOUT CRT and ensure that the patient does not require an upgradation in future.
Yeah, we can see it is always safe to combine two therapy. You can always put a left bundle lead. Then it not practical most contrary to belief the reduction aggressive more than 90% time. Even intrahesian disease, infrahesian blocks that can be corrected just being distal to the His bundle more than 70%. So is a wrong probably perception that patient who has got right bundle branch block, it's always a focal disease in majority.
In this case, beside the left bundle lead, should we place the ICD lead also? I think we should, because there is a scar. We are doing a procedure. We are already giving.
Yeah. So that argument of doing the procedure and putting ICD, probably I would not, because this patient has got scar. Patient has syncope, but no documentation of any arrhythmia except some pauses which are very non. So what I would like to do in this is to have a study tells that there is a conduction intrahesian or infra, and I would still pacemaker.
So I think this
Conduction
whole
system
concept
pacemaker.
that because revision is going to be more cumbersome and is most likely to have complication often tends to make other operators think that बाद में करना पड़ेगा तो पहले ही कर देते हैं types is probably not scientifically justified. Again, scar burden, again, as I was saying, you need to quantify. You can have scar non-ischemic etiology as well. So you may have a scar from a myocarditis, you may have post-COVID, you may have a scar of ischemic etiology but not amounting to the myocardial infarction. So guided by that probably and approaching. So I mean, like for LGE quantification on an MR in HCM, we have clear-cut cutoffs, like 15% always do, 10 to 15 borderline, less than 10 don't. you put an ICD in HOCM. But do we have this kind of quantification for MR-based, scar-guided ICD insertion in ischemic etiologies?
Can be used as a adjunctive what patient. So if patient has reduced ejection fraction, he becomes a candidate of ICD. But if patient has non-ischemic problem and there is a scar, like as you told HCM, or patient with sarcoid who has presented with AV block but has no PT documented and has got significant scar, still those patients become a candidate of ICD with normal EF. So reduced EF, scar analysis has not that much compared to relatively preserved EF, except non-ischemic cardiomyopathy.
Just last one, just I wanted to point out that considering here that putting an ICD if at all as an option, but the patient having maybe recurrent episodes of cardiogenic syncope and probably the scar VT as an etiology, then are we in a soup then? And probably the ICD just repeatedly firing and giving shocks, and we have not done substrate mapping. That is what I just wanted to convey.
That is the reason why first slide, that approach of EP study, long-term accountable is suggested, because you after also I may miss out can happen, but that is the reason why they need to be evaluated clinically like all the patients.
And one more point, just wanted to point out that the induction of scar VT, there is also a very much a gray zone as to sometimes you may not be able to induce the scar VT itself. So not necessarily that if at all the scar VT is not induced during the EP study, it might still be occurring later on.
Yes. So again, then comes the ejection fraction, because with keeping everything, see, these are not 100% specific tests. What we are trying to do is maximize the number of patients that gets benefited from these devices with minimal chances of missing out the patients which probably would have benefited by their choice.
All right, so thank you very much for a wonderful discussion. We had very good presentation and take home, and there was a quiz.